Good evening and welcome to Conversations Live Cancer Treatment. I'm Patty Satalia. Tonight's, in 1971, President Nixon declared war on cancer. Almost 41 years later, how are we doing? Tonight's guests will talk about that and about the latest in conventional, alternative, and complementary methods of cancer treatment. They'll also take your questions. Our toll-free number is 1-800-543-8242, and our email address is connect@wpsu.org. If you'd like to join us on Twitter, you can tweet a question to @WPSU. Now let's meet our guests. Ralph Moss is a leading author and consultant on cancer treatment and alternative cancer therapies. He's written hundreds of articles and numerous books on cancer, and his Moss reports provide information on more than 20 types of cancer. Jerry Durdell is the director of radiation oncology at Mount Nittany Medical Center and State College and an assistant professor of radiology with Penn State's College of Medicine. And Vitek Rybka is the director of the bone marrow transplantation program and the chief quality officer at the Penn State Hershey Cancer Institute. He's also a professor of medicine and pathology. Thank you all so much for joining us.
You're welcome.
This year alone, nearly 600,000 Americans are expected to die of cancer. That's more than 1,500 people a day. I'm going to begin with you, Dr. Moss. How would you characterize America's cancer problem?
Well, it's huge. The cancer problem is huge. And, you know, I've been in the field since 1974. At that time, there were, I remember, 365,000 people, Americans, dying of cancer. Of course, the population has grown and the population has aged, so it's not as if, you know, it's grown by epidemic proportions, but we're more or less keeping pace. There have been some major advances, and there have been a lot of disappointments. So you could focus on one or the other exclusively, but I would say that we still have a long way to go, and I feel like we need an infusion of new ideas into the field in order to take advantage of every possible opportunity for finding better treatments.
And we'll talk more about that in a moment. But Dr. Durdell, we're 41 years into America's war on cancer. What would you add to what Dr. Moss says? What do you see as the major accomplishments and on the flip side, maybe the major disappointments in our war on cancer?
Well, I've been here since 1984, and during that time, there have been significant advances, certainly in my field in radiation oncology. We've seen changes in equipment, changes in diagnosis of diseases, and changes in the ability to identify what our targets are and what tissues we want to avoid. Along with that, we have better equipment that are able to pinpoint cancers and treat them more effectively. The problem is cancer still is surrounded by normal tissue, and we, you know, with better techniques, we should be able to just treat the cancer cells and not the normal cells. Right now, they're just starting to get into that. Radiation can treat a tumor, but still it has to go through normal tissues to get to it. So we've made a lot of advances, but I think there's still room for a lot of innovation and a lot of improvements.
Dr. Rybka.
Well, the war idea is a kind of a catchy phrase. It's an unfortunate one. It suggests there'll be one big battle and it'll be done and we'll have won.
And perhaps cure isn't even the right word, is it?
No, I don't think so. So in those 41 years, there are tremendous advances in knowledge. And I think that's the biggest victory. So the mechanisms of how cancer develops, how it propagates, what the signals are, learning how to target specific mechanisms of abnormality within the cancer cell and within normal cells as well has led to major new treatments and major new promises.
You just said something that leads me back to Dr. Moss, and that is a book that you are championing, and that is Cancer as a Metabolic Disease. It was written by Dr. Thomas Seyfried. You say this book revolutionizes our understanding of cancer. So what difference does it make if we look at cancer as a metabolic process rather than as a genetic problem?
Well, it wouldn't seem to make such a big difference because everybody recognizes the fact that cancer is abnormal at the level of the genes, And cancer is also abnormal at the level of the metabolism, that's to say the way in which it generates energy. So there's not really much of a debate about that anymore. The question is, which process drives the other one? And the great majority of scientists believe that the genome rules. I mean, basically cancer is a genetic disease, and that's making the metabolism go bad. Then there's a minority of people who believe that the fundamental problem is in the metabolism and that actually can make the genome defective. Seyfried believes the latter. And it was very interesting to me. I went up this summer and had lunch with James Watson, who co-discovered the structure of DNA in the 1950s. And one of the amazing things is that Watson now is putting his emphasis on metabolism of cancers. Craig Thompson, who's the president of Memorial Sloan Kettering, that's his field now, is metabolism of cancers. The whole approach to treatment will, and of course the thinking about cancer would be different if cancer is a genetic or a metabolic.
So how so?
Well, because the problem with from a practical point of view, the problem with the genetic approach is that there are many genetic changes in a tumor. There was an article in Science last year that said that there's up to 100,000 genetic or mutations in a lung tumor. It's inconceivable to me, how are you going to approach that kaleidoscopic problem of all the different genetic changes? And I think so far we haven't seen, with a few exceptions, we haven't really seen very much progress using these genetically targeted agents. If cancer is a metabolic disease, then you can look at things like its use of sugar and the fact that the tumor has a great need, if you will, for glucose, much greater than that of normal cells.
And so if you quit eating the American diet of sugar,
well, there is a scientist
you may not trip this gene that
well, there is a scientist named Walter Longo at University of Southern California who's shown that you get better results with chemotherapy if you go on a water fast for 2 days before doing the chemo. And I mean, this has gotten a lot of favorable press in Scientific American and so forth. The number of metabolic targets is actually very small. I mean, it's glucose, it's glutamine, it's a few other things, but you could see how you could starve a tumor using some drugs that are already available, like metformin, and then new drugs that are in the pipeline. A couple of companies in Boston that are doing this.
So what do you think, Dr. Rybka, of this metabolic approach to cancer? And then I want to take our first phone call. Well,
I think it's a matter of the cart and the horse, and you're trying to figure out which is which. I look at cancer as a growth and development issue, and that we, in all our tissues, are constantly developing, growing, replenishing, and then dying off. And in that process, the major drivers are controlling elements in the genome. And that genome, once it becomes disordered, these things become very unbalanced. And there are a lot of metabolic consequences of all of that. You sort of put one wrench into the works and you have a huge downstream effect. So there is an initiating feature. There's been plenty of starvation of cancers. Cancer is this sort of self-starve. You're cachectic, meaning you lose a lot of weight, and so on. So the essential nature is that cachectic state. And yet it propagates the cancer rather than cures it. So it's an issue of, the other issue is then how you look at managing a cancer. Because once the damage is done, those consequences are the ones you have to reverse. And now you're not going to reverse the original damage, that's sort of permanent. It expresses itself and then in the cell living and dying, and how you manage that will control the cancer or it won't.
Okay, and we'll get back to that, I think. We go now to Don, who was calling us from State College. Don, go ahead, please.
I would like to ask the panel, or just give the panel's input on the, given the amount of donations and contributions, monies raised for cancer research, FON, for example, but there are many of these programs across the country, and given the span of years that this money has been raised, have we gotten the
Our money's
return
worth
on that investment?
An interesting point. 41 years and tens of billions of dollars spent on cancer. Have we, Dr. Durdell, gotten our money's worth?
Well, we have a lot of progress. I mean, I think we've made a lot of progress in understanding the disease, both on the basic level of what causes it to some degree, but also in how to treat it. There's now many, many more forms of treatment that were not available years ago, and a lot of these have been pioneered and
But if you look overall at cancer, you see that there are a couple of cancers for which we've made some progress. 3 for men: prostate, colorectal, and women, fewer deaths as a result of cancer. But then there are hundreds of others which are on the rise.
And I think we have to distinguish between local tumors and metastatic disease, stage 4 disease. The technology for eliminating local tumors gets better and better. That's surgery and radiation, basically, with the help of chemotherapy. But and some other areas have we made a lot of progress, like adjuvant treatment for breast cancer for high-risk women with high-risk breast tumors. But for metastatic disease, which is unfortunately the state that, you know, hundreds of thousands of people still find themselves in, I think we've made much less progress. A very tiny fraction of the research funding goes into studying metastases. It's somewhere between 0.5% and 1.5%, something like that. So I think that, you know, that's the tough problem. What do you do once the cancer has spread? And that's where, you know, I think people like James Watson are trying to look down the road and say, where did we go wrong with this? Because we don't seem to be making great progress, with a few exceptions, and we could talk about those exceptions. But if you look at the big picture, the common kinds of cancer, no, I don't think that we've made much progress in terms of definitively treating. And we seem to be able to extend survival by some months in those cases, but I would have expected a lot more progress in the 41 years that we've had than we've actually seen.
I'm going to come back to perhaps what we should be doing, what you think we ought to be doing, but first I'll take this call from Catherine, who's calling us from Hollidaysburg. Catherine, go ahead, please.
Hi, my name is Kathy Griffith, and I'm Dr. James Moser's pancreatic advocate of Beth Israel Deaconess Hospital in Boston. And there was a young man that we came across, Dr. Moser and I came across. His name is Jack Andraka, and he's the winner of the Intel Science and Engineering Fair in Pittsburgh, PA. And he has a detection test for pancreatic, ovarian, and lung cancer. And, you know, he really has been working with Dr. Mietra at Johns Hopkins, and there really is hope on the horizon for early detection. Were you aware of Jack Andraka?
I see some people shaking their head, but can you tell us how the detection is accomplished with this new device?
Yes, he has created a sensor stick. You can Google Jack Andraka. There's a lot about him on the internet. This all happened in Pittsburgh, May 2012. Dr. Moser and I had reached out from him from BID and talked with him, and he came to Altoona. He was here to give a talk at the casino in Altoona, PA on July 27th. And this young man has a sensor, test strip, and a urine dipstick, and it tests for mesothelin. And it'll be like a 3 cents per testing, and he's patented this, and it's coming along pretty good in the trial period. Let
me see if our panel members have any comment.
I did read about this.
Okay.
Yeah, I mean it's pretty extraordinary. I wish him luck. I've seen, in the course of my almost 40 years in the field, I mean, I've seen so many promising treatments and tests come and fail to be commercially developed that, I hope this one will be different. I mean, there are things out there. I've written a book called Customized Cancer Treatment about pre-testing tumors in the laboratory in order to determine which drugs are most likely to work or not work. And now this is starting to get some traction. But if you know the history of this, I mean, it's decades of trying to develop this. So I wish you all the best. Sounds very exciting what you're doing.
All right, thank you for your phone call. Milfred from Smethport, you're on the air. Go ahead, please.
Hello.
Hello. Do you have a question for our panel?
Yes, I wonder why I've survived stage 4 cancer in my lungs and my liver. They had it cancer-free. It went to my brain. I took 10 treatments of radiation for my brain. I'm still here. You're talking about some kind of a chemo, maybe to continue a little bit, but I just am thankful for being here, but I just wonder why I'm here.
Dr. Trudeau? Oh, go ahead.
What kind of cancer do you have, sir?
Well, I had it in my lungs and my liver.
No, but what was the origin of the cancer?
I'm not sure what it's called, but now it's in my. They said it was in my brain, but maybe they gave me radiation. Maybe they got it. I don't know.
Your cancer usually starts in an organ, a place, and there are many cancers. I was going to sort of address the last caller with thinking about systems of disease rather than just single diseases. Certainly, cancer is not a single disease, and in this case, depending on where that cancer started, as Dr. Moss said, it.
20 years ago, I had it. I survived prostate cancer for 20 years. I've survived that.
Right. So cancer spread to other organs, and the lung and the liver are common ones. It depends what that original cancer was in terms of its behavior. Some things can be very slow and smoldering, and some things can be quick and dramatic. So if you're fortunate enough to have one that sort of evolves very slowly, you do live a long time. I think one of the things that people feel about cancer is that it's always catastrophic and something's going to happen the next day. But that's not true. It evolves over years. And the better you live with it, the more successful it is.
People often also think that it's a ticking time bomb and they have to do something immediately. How often is that the case, where they have to decide which treatment they're going to pursue and begin it immediately?
Well, there's certain. I happen to treat leukemia, and that's an explosive disease that evolves over a 6-week time span. But I'll mention my mother-in-law. So she, back in 1977, had a breast cancer, and it spread up to a lymph node in 79. She had that treated. Nothing happened. And then about 7 years ago, developed a lung cancer, apparently different. She's 93, and she didn't want to treat it and just leaving it alone. She's gone through a couple of doctors just tapping them, holding their hands and saying, "Now, don't worry, it's not that bad." And she's just going along very nicely with it. It might be her original breast cancer. More likely, it's a lung cancer. But she's had two slowly evolving things that have let her live to 93 quite happily.
And it's funny, if you look in the SEER database, which is the big database of all the cancer cases and cancer mortality. You look back in the days, in the 60s, let's say, when there was no chemotherapy, there were no effective treatments for stage 4 cancer, you still saw a residue of about 5% of people who were surviving long-term with those diseases. Without any effective treatment. So people think that it's necessarily a death sentence, but it's a very unpredictable disease. And then the disease can change too. I mean, it can go along for a while, smoldering. But to answer your question, as a rule, you have to treat cancer very promptly, as a rule.
That's right.
I don't want to give people the impression that, you can just sort of let it go. But different cancers in practice, they grow at different rates. I think you shouldn't decide so quickly that you've interrupted your proper decision-making process. But I always tell people, it's a matter of making a decision in some weeks rather than in some months. Months is too long. Weeks, you've already had this cancer probably for 7 years or something. You need to make the right decision. And oftentimes, nowadays especially, it's left to the patient to be very proactive in terms of which treatment to choose.
And I'm going to talk about that in a moment. Did you have something to add, Dr. Driddell?
Well, it's important that the patient doesn't rush in, as you said, to give them enough time to investigate what the treatment options are and give them the time that they need to be comfortable to make the right decision. One of the exceptions is prostate cancer. Prostate cancer tends to be in a lot of people a slower growing tumor, and patients ask me, do I need to do something right away? And oftentimes one of the options is to do nothing, is just to do observation or expectant management, as they call it. And if they wait months or even years, sometimes it makes no difference at all. So that's really one of the big exceptions.
Dr. Ripka.
I'm going to take some issue with a thing that you said, that you can't predict how it's going to behave. And I think actually you can, very, very nicely actually. So part of the research of many years has been to catalog, describe, establish the natural history of many cancers, so that when you get a cancer, it's very important to biopsy it, to establish the characteristics that are there in the tissue, to look at the genetic changes within the cancer, to look at a number of features that are called markers of the disease. And it does really predict well how that particular cancer is going to behave. So certainly you can pick up the very explosive ones, the ones that put your life at high risk. And like the prostate cancer, you can establish ones that are going to be very indolent, and you can advise to sit back and wait.
Now, you mentioned biopsy, and of course there are PET scans and CAT scans and biopsies as a way of diagnosing cancer. Biopsies scare some people. They're afraid that by biopsying this, that you have released the cells and that you are allowing the chance for cancer to spread. How do you respond to people with that fear?
Well, you have to talk them through it, but it is a myth. And it's a well-founded myth. Dr. Halstead propagated it years ago, back in the 1890s, and it dominated thinking for quite a while. But it clearly is not the case. And knowing exactly what you're dealing with really arms you in being able to treat the patient, their symptoms, and so forth. So no, when you cut into it, it doesn't magically spread. Oxygen does not promote the cancer. And the characterization is critical to proper treatment. Okay,
if you're just joining us, I'm Patty Satalia, and this is Conversations Live Cancer Treatment on WPSU TV and WPSU FM. Let me reintroduce our guest. Dr. Ralph Moss is a leading author and consultant on cancer treatment and alternative cancer therapies. Dr. Jerry Driddell is the Director of Radiation Oncology at Mount Nittany Medical Center and State College, and Dr. Vitek Rybka is the Director of the Bone Marrow Transplantation Program and the Chief Quality Officer at the Penn State Hershey Cancer Institute. Our telephone number is 1-800-543-8242, and our panelists are ready to take your call. You can also email your question to connect@wpsu.org. If you'd like to join us on Twitter, you can tweet a question to @WPSU. And we now go to Kay, who is calling us from State College. Go ahead, please, Kay.
Thank you. My first question, I have two, please, is what about the holistic approach of looking at the emotional concerns for cancer, and what kind of a concern should we be having for treating the whole person as part of the problem? My bigger question is, should we be looking at a little more freedom of health for people and allowing them to make decisions on their lives where they're now currently get a hard time? Like I'm thinking of Brzezinski, and early on Kelly and Gonzalez picked up his work, the Gerson therapy. Many of these alternative doctors have to have clinics in Mexico because they're not allowed to practice things. And I'm wondering if there would be any more advancement in cancer if we have a little more freedom of health to allow people to choose what they want to choose, especially if they're working with stage 4 cancers. And all of these people seem to be involved with this metabolic approach. So I appreciated your talking about that. Thank you very much.
Thank you. We'll begin with Dr. Moss.
Well, you know, I wrote a book 30 years ago called The Cancer Industry. And I had a chapter about Brzezinski and some of the other people.
And I think you need to give our audience a little bit of a background.
Well, a background about...
Brzezinski.
Oh, well, Brzezinski was, Dr. Stanislaw Brzezinski is just one, as the caller indicated, just one of quite a few people who have proposed different ways, alternative ways of treating cancer.
And was vilified.
Yes, but there's always two sides to every story, and so I think that we have to take a scientific approach to all of these treatments. That's sometimes difficult because sometimes the proponents themselves don't take a scientific approach. So it leads into into an antagonistic situation. And that, I think, isn't serving anybody's purpose. There is a possible reason why Brzezinski's medicines, which are called antineoplastons, might work. They block the uptake of glutamine, and glutamine is an alternative fuel source for tumors. And I wrote Brzezinski about this a couple of weeks ago, and he did confirm that he agreed with me that that might be one of the mechanisms of action. But, he's a kind of a special case, Brzezinski. The other cases, I guess my attitude has changed a bit over a 30-year period. I agree with the caller. I think that people should have freedom of choice in medicine and making their choices, and they shouldn't be coerced into taking treatments. And that sometimes does happen. But on the other hand, I think that there's a heavy responsibility on anybody proposing a treatment to fully document the rationale and the effects of the treatment. So that's my...
You often say, though, that complementary and conventional medicine can work very well together. And you talk about Germany as the place where that is working the best. Right.
But most of the German clinics are integrating conventional with non-conventional treatment. So in other words, the perfect example is hyperthermia, heat therapy.
Heat with chemotherapy.
Correct,
with
but
radiation.
it's always given with radiation or with chemotherapy. And there are now 2 very fine clinical trials that have come out of Germany and out of Holland to show that adding hyperthermia to chemotherapy for soft tissue sarcoma and adding hyperthermia to stages 2 and 3 cervical cancer with radiation, as they did in Holland, yield better results than doing those alone. And in fact, this year, FDA approved the BSD 2000 machine, which is an American-made machine for delivering heat therapy. They approved it for cervical cancer, and we're going to see this now being used in about 5 or 6 centers around the U.S. This year will start using it.
Something that's been used in Germany for decades.
Well, yes, but never really proven by randomized controlled trials. So now we have the randomized controlled trials. I'm enormously frustrated by the lack of access for patients to things that are showing benefit, especially in other countries that we're not given access to. Plus, I think it's just a matter of treating people with respect to allow people who have advanced disease for which there really are no curative other treatments to make their own choices in terms of what treatments they're going to go for.
I'm going to take another caller in just a moment, but Dr. Durdell, how do you respond to what he says? When you talk with patients about radiation, for example, do you also offer other complementary therapies that they might consider? How important is that?
Well, I think it is important. I think it's more driven by the patients. The patients are very interested in it. There's a lot of money spent, and the people travel with their money. They will go to places that offer this. I had a patient that went over to Europe to get a treatment that wasn't available here. I think we need to investigate these. I certainly agree with that, but they have to show, they have to be rigorous and they have to follow scientific principles. And if they do, I think that we'll, hopefully see them introduced appropriately. It was interesting, hyperthermia, colleagues of mine used that when I was at Jefferson as a resident back in the 1970s.
And with what results?
Well, with some good results. The problem was the technology didn't advance enough to get deep tissue heating, and so it kind of went by the wayside, and now that they've developed these better equipment, it's coming back. So, yeah. And there's a good scientific basis for it.
Okay, so it's some hyperthermia, PER thermia.
Hyperthermia,
yes,
yes.
is something that you think we'll see more of in the States.
We will, yes.
Okay, we go to Walter, who is calling us from Warren, Pennsylvania. Go ahead, please, Walter.
Ms. Satalia, first of all, thank you for taking my call. And the question I propose to your panel has to do with the United States Public Health Service recommendations regarding two issues. One is the frequency of mammography for breast cancer screening, and the other has to do with the utility of prostate-specific antigen blood tests for the early identification of prostate cancer. And I'd be very interested what your panel has to say about these issues.
Dr. Rybka?
Well, I think that's one of those areas where rigorous testing has occurred. And you look at the whole thing in terms of a balance of risk and reward. So in mammography, for example, that requires a fair bit of radiation over the years. And so how much cumulative radiation is necessary? At what age and at what sort of situation you pick up the highest frequency of breast cancers? When do you pick up the earliest breast cancers? Are the mammography techniques efficient and effective in picking them up at the right time? So those are all questions. So that's led to these recommendations of a mammogram every 2 years, and a big discussion whether you should start at 40 or start at 50. What's your mother's history? What's your grandmother's history? And so on. Changing those recommendations, identifying
and what do you
high-risk
think?
groups.
Starting at 50 and every 2 years, is that adequate?
If you have no family history, you have a low-risk situation. If you have a high-risk situation, I would propose earlier. And we've all seen women in their 20s and 30s with a breast cancer, quite unfortunately. Prostate cancer, since my family is rife with prostate cancer, it's just quite interested in that. The question of the screening PSA, how often it actually provides a benefit as well is at issue. Now, since I have a father and 2 uncles and a first cousin with breast cancer and so forth, I think I'm high risk. I personally have my PSA done, but I belong to a high-risk family. On the other hand, 1 out of 2, 1 out of 3 men will die with prostate cancer and never have suffered from it. And the disease will have been there for 20, 30, 40 years. So it is one of those, in the proper age groups, an indolent one. If you find it at age 75 or 80, life is pretty good. If you find it at age 40 or 50, life is terrible. So again, the recommendations are based on that. There's also another aspect, is the more you look, the more you find in terms of abnormalities, and then now you start causing trouble. You cause complications of the testing procedures themselves, and they can be quite important. Simplest thing is in early resection or even early radiotherapy of prostate cancer that will be indolent. You produce impotence, you produce sexual dysfunction. So all of these things have to be taken into account in those recommendations.
Okay. If you're just joining us, I'm Patty Satalia, and this is Conversations Live, Cancer Treatment on WPSU TV and WPSU FM. Let me reintroduce our guest. Dr. Ralph Moss is a leading author and consultant on cancer treatment and alternative cancer therapies. Dr. Jerry Dredell is the Director of Radiation Oncology at Mount Nittany Medical Center and State College. And Dr. Vitek Rybka is the Director of the Bone Marrow Transplantation Program and the Chief Quality Officer at the Penn State Hershey Cancer Institute. Our telephone number is 1-800-543-8242, and our panelists are ready to take your call. I do want to do a quick follow-up with you, Dr. Dredell. You wrote a paper, actually, about technological advances in radiation for prostate cancer. Can you tell us something about what's available today that perhaps wasn't a decade ago? There's
been tremendous advances in the treatment of localized prostate cancer. On the surgery end of it, which obviously I don't do, but they've gone from simple prostatectomies to nerve-sparing prostatectomies to laparoscopic prostatectomies, and now robotic-assisted laparoscopic prostatectomies. These allow, better removal, or at least more accurate removal of the gland itself. Most importantly, a quicker recovery with less potential side effects. On the radiation point of view, we have multiple options, and these include external radiation, which we use IMRT, which stands for intensity modulated radiation therapy, and IGRT, which is image guided radiation therapy. And really what that means is the ability to target the gland even if the gland is moving. So we identify where the gland is on a daily basis before each treatment, and so we can just target that gland alone, and that allows us to spare the normal
minimize
tissues.
the damage of healthy tissue.
And also, if you can do that, there's ways of shortening the course of treatment, which is a big factor in cost and in patient inconvenience. The other big option is prostate seed implants, which we've been doing here for many years, and that's just an ideal way of providing very what we call conformal dose, that is dose that's fit just to the target, which is the prostate itself, and very effective in treating prostate cancer.
And this sort of goes back to what Dr. Moss said about customized cancer treatment.
Yeah. We're seeing, of course, the movement towards personalizing. But I think in prostate, the problem is that all of the methods that I'm aware of involve some risk of impotence and incontinence and urinary incontinence, and that's a terrible thing, especially if you're for a younger person to face. What do you think about HIFU, about high intensity focused ultrasound? Have you looked at the studies for that?
Yes, I have, and I've talked to some people that have done it. The problem is in radiation you have a way of monitoring dose. And you have clearly know what dose you take, and they've done dose escalation studies and found out what the tolerance is. In HIFU, it's not.
And HIFU, for those who've never heard of the term,
it's a kind of ultrasound used therapeutically. So you use a high intensity sound wave to destroy the.
And the benefit is that it doesn't destroy the healthy tissue.
Well, there's a couple of benefits. I mean, one is, purportedly, there is fewer side effects, or less commonly have side effects. Secondly, you can retreat with it. Yeah. I mean, it's not it's radiation, but it's not ionizing radiation. Right. It's not the most harmful kind of radiation. So if there is a recurrence after you've done the HIFU, then you can treat again with it. But the interesting thing to me is that Cleveland Clinic has opened a HIFU center in Canada. Mm-hmm. It's called Maple Leaf. It's actually run, so they've kind of gone offshore. I mean, Cleveland Clinic is a very good hospital, excellent, and they've gone offshore with this because, again, I mean, FDA seems to be erring on the side of caution.
Well, you've said in the past that something like hyperthermia, if it had been a drug, it would have been more widely used in this country.
Yeah, I mean, hyperthermia has a lot of economic problems. The machinery, to get approval, they have to raise the price of the machinery to the point where it's not economical for most centers to have it. And you have to train somebody, you have to find somebody or train somebody to be a technician. I mean, like University of California, San Francisco, their quote-unquote technician for hypothermia is a PhD physicist. So to really do this right, you have to have somebody of high skill, intelligence, knowledge, and, just like you do for radiation. It's a very costly process, and it's only going to, it has to snowball, and it hasn't yet achieved that kind of momentum. But HIFU, it's been, it's just been on the periphery of medicine, I think, for so many years, and everybody's looking for something in the treatment of prostate cancer that would be less devastating in terms of the side effects. If you come up with that, a lot more people will be treated, I think, who are now holding back from treatment. And the watchful waiting, or, whatever they now call it, is okay, but you still fear that somebody's going to go through the net, and while they're in the process of between interval cancers between the cancer could spread. Okay. So it's a dilemma, very big dilemma.
All right, we go to Bill, who is calling us from Mill Creek. Go ahead, please, Bill.
Hi, thank you for taking my call. I have prostate cancer, and I'm just about exhausted the menu for treatments, all the way from radiation through Taxotere and Jeftana. My oncologist has recently discussed two possible treatments with me, one called Provenge and the other one called Zytiga. I'd like your opinion or your point of view, especially in light of what you said earlier about the rationale for treatment and the effects of treatment. Thank you very much.
Before our panel answers, how old are you, if you don't mind my asking?
I'm 82.
82? Oh, you don't sound 82. I thought that might be helpful information to have. Who'd like to start? Dr.
Yeah, I could talk about Provenge a little bit. Provenge is a very unusual drug because it's a dendritic cell vaccine. So in other words, it's the first immunological treatment ever approved by the FDA. It's been around for about two years now, or at least it's been approved for about 2 years. A dendritic cell is a presenting cell. In other words, it takes the marker of the tumor and holds that up like a sign for the killer cells in the immune system. And there is a clinical trial to show that Provenge will extend survival in advanced stage prostate cancer by a few months. Maybe more. Maybe it's actually a few more months than they originally thought, but it's not terrific in terms of its effects. In fact, the FDA very strongly resisted approving the drug, but patient groups pressured them, I would say, to
And what are the
approve it.
side effects if he were to undergo that treatment?
I don't know. I'm not. That's not coming up in the little gray cells.
Dr. Ripka?
Not so many side effects as effect or lack of effect.
Lack of effect.
Yeah.
So it may be worth a try.
Yeah, it's interesting that one calls it a drug. It's not. It's a reaction that you try. So you're trying to harness various aspects of the immune system to target it against the cancer. And that's the whole sort of basis of tumor vaccines in general. Now, there's many of these in development. They've been very hard to show that they have lasting effect. That they have effect is true. You can show destruction, you can show shrinkage, you can show control and so forth. But it is somewhat short-lived in general, although there's a number of techniques now to try to extend that dramatically. On the other hand, these are complex treatments. You're not targeting one thing. You have to have kind of an intact immune system to do it, and you have to promote the right components to get an effect. So there's not a simple answer to this. It's something to consider as treatment. It's still a drug or a treatment of the future.
Okay.
Can I say one more thing? In Germany, there are a couple of clinics that have used dendritic cell vaccines for quite a few years. And it's interesting to me that the one that had the most experience with it found that they had to combine it with other treatments like viral therapy, which is legal to do in Germany. It's only done in clinical trials in the United States. When they combined this Newcastle disease virus vaccine with dendritic cell vaccine, they got a much better result. So my feeling is, generally speaking, in cancer, you want to triangulate. In other words, you want to bring a number of things against the cancer. You could call this a cocktail approach. My friend Raymond Chang in New York has written a whole book about this called Beyond the Magic Bullet, that sometimes things that don't work so well individually alone work quite well when you use them in combination. He uses the case of treatment of AIDS. Where you have a cocktail that is able to quite control HIV/AIDS quite well, but individually those things are not terribly impressive. So that's what they're doing in the German clinics, and they do as much as they can. They come at it with hypothermia, with viral therapy, with dendritic cells, with other vaccines, and that seems to be the best we can do right now. But individual drugs, when you try to analyze them singly or in a kind of reductionist way, most of them come up short.
Okay, we're going to take another phone call. We've got Sue from Lamont on the line. Go ahead, please, Sue.
Hi, I have a question and also a comment. The
hyperthermia
therapy, is that also a treatment that's heating the blood? said they take the blood out and heat the blood and put it back in?
That is one form of hyperthermia, but...
Yeah.
Go ahead.
I had a friend who had that 28 years ago for melanoma, and she's perfectly fine. And she was told she had 6 months to live.
That's pretty amazing.
Yeah, I thought I never had heard of it, and then it happened. I was diagnosed with breast cancer 28 years ago, stage 3. I was premenopausal. And I just wanted to comment on the difference. I had it again in 2009. It was a breast cancer, but it was not an estrogen receptive one. But when I had it the first time, the oncologist thought that only chemotherapy would work. The radiation person said you'd only need radiation. The surgeon thought it was just the surgery that you needed. And when I had it the second time, there was a conference, and the oncologist, the radiation therapist, a psychiatrist, and everybody else talked to each other. And then they talked to me about, these are the choices that you have. And it was just so much better the second time to have that cooperative feeling rather than a feeling like I had to decide among all these things without really getting a chance to
And imagine
them.
having them all in the same room to bounce that off of. How common is her experience?
It was really interesting.
Well, unfortunately, it's becoming very common.
Yeah.
It
was just so much better for the patient.
It definitely is. And it's better for the clinicians, to present all the information, review it together. Most centers have cancer conferences, so we have them at Mount Airy Medical Center, and all major cancer centers have them. And we discuss patients, we look at x-rays, we look at pathology reports, we have all the major specialists there, and we talk about cases, and we talk about what might be better treatments. We don't always agree, but we try to come up with a consensus, and I think that benefits the patient always.
All right, thank you for your phone call. Based on your personal experiences, what characteristics or what's required for the best outcomes? And I'll begin with you, Dr. Ripka.
Well,
is it this team-building approach that
there's no doubt about
that?
I just started thinking back, you were saying 74. I graduated from medical school in 72 and started training in cancer about 75. The world has changed dramatically in all that period of time. So it's obtaining and applying specialized knowledge in the context of kind of a team effort, and keeping up to date with the rapid advances that are coming on. It doesn't mean that there aren't standard approaches and so forth. There are. But they get modulated constantly as we understand more and more about this. So I think that's really what's at issue.
Okay, I have an email question I'd like to pose. Can Dr. Ripka speak to liquid biopsies analyzing circulating tumor cells, CTCs, from tests such as FDA-approved Cell Search for cancers?
Yes, well, it's sort of an intersection of theory and practical application. So the question is, can you replace other biopsies with such specialized techniques? And the answer is not yet. So you still need to know what the original tumor is like, what's surrounding it, what its characteristics are. However, one of the theories, and I happen to sort of support it very strongly, is that tumors, like all our organs, have a set of stem cells that drive their growth and maintenance as a tissue, and that you can capture these cells in the blood and use them for diagnostic purposes and for drug testing purposes. It isn't sort of widely validated yet in terms of those kinds of applications, but those are the research directions that are going on. So will you be able in the future to derive knowledge of a tissue without actually sampling the tissue? Maybe. There's other fields like proteomics, genomics, metabolomics, where signatures of tumors are being found in the blood, in the circulation, to achieve such ends.
So you may not in the future need the biopsy.
May not, but that's a long way to go.
Cell search,
long way to go.
Cell Search is only 70% accurate in stage 4 breast cancer. So we know that the women with stage 4 breast cancer have cancer in their system because it got from one place to another. It was presumably in the blood. But 30%, the test will fail to find
30% of the time.
in 30% of the time. So that's the reason that even though FDA approved it, it doesn't have any legs because nobody's going to put their money or their time into a test that is only 70% accurate. Although I think it's better in terms of ruling in rather than ruling out. I did hear at the ASCO meeting this year that Massachusetts General Hospital has a test in the works that is going to be much more effective than that. And there are at least 4 labs in Europe that claim to be able to analyze circulating tumor cells and make treatment predictions or recommendations based on that. The trouble is that none of those have been independently verified. So there is sort of a kind of a market for this, but I have a feeling that in the next year or two, we're going to see something coming out of academic medicine in the U.S. that's going to blow away the cell search. And I talked to the cell search people at ASCO. I mean, they themselves didn't seem to be at all enthusiastic about their own product. So that's never a good sign.
Right. We go to Ron, who is patiently waiting in Crescent. Go ahead, please, Ron.
Doctors, thank you very much. My question has to do with HER2 receptors. To give you a real quick background, my wife was diagnosed with breast cancer. We had her in Pittsburgh at McGee, and they did a lumpectomy, and at the time told us that she had a HER2 receptor. Now, this went on for about a year, and now she developed some tingling in her right hand, and it was diagnosed that she had a tumor in the brain. And we went down to Pittsburgh, and they did a craniotomy, and then we were given. She was given the gamma knife. And my question is after gamma knife, is there anything that they're recommending to follow up with medication, or what is the future treatment with the HER2 receptors?
Now, her tumor was HER2 positive?
Yes.
Okay, and then was she treated with Herceptin?
Yes, she was. So we came to Altoona. They set up the protocol for us, and we came to Altoona, and we finished the Herceptin program. So
that's a good example of characteristics of a tumor and selection of treatment specific for a subtype of the tumor. And the breast cancer is expressed as HER2 receptor. It's the HER2 is very critical in the growth of the cells and so on, but there are specific agents targeting it, and this allows very specific therapy tailored to her. That would be different from someone who is more of a hormonally based tumor. It would be treated with an aromatase inhibitor, for example. Now, having had it in the brain, the issue is it anywhere else? And that's why the staging's sort of repeated, and you look for traces of the cancer elsewhere. The brain's a very privileged place, and the tumors can lodge there and escape therapy that's given intravenously or given systemically, because the brain's very adept at protecting itself from any kind of invading substance. So it's called a sanctuary, and that tumor doesn't get exposed to her treatment and proliferates. Now, hopefully she has a single focus, and that gamma knife may be all that she requires. So at the present time, if there's no evidence of other metastatic disease, you wait. But it's because of that combination of factors, the fact that you can treat, we call it systemically, in the body, but the brain's protected, and you have to pay attention to the brain as a specific site, and then tailor that therapy to that specific site.
Unfortunately, we probably have 5 callers in the queue and not time to get to a call. But I would like to just do a quick 30 seconds each around the round robin. What advice would you have for listeners and viewers in terms of preventing cancer?
Oh, well, I mean, I think that diet is very important, and exercise. My own personal belief is that people should avoid sugar and highly refined carbohydrate products. I think we see that, of course, everybody knows to stop smoking and have any contact with, with inhaled smoke. Aspirin seems to be protective against colorectal cancer and some other kinds of cancer. And there are some other common drugs and even vitamins. We now know that vitamins are protective for some people. So lifestyle would be my recommendation.
Okay, Dr. Driddell?
Yeah, absolutely. Just to reiterate, obviously, smoking cessation is one of the biggest. It's related to the 30–40% of cancers and many other diseases, but also the weight loss. To maintain more normal weight. Diet is important, as you pointed out, maintaining good, healthy diet with decreasing sugars and stuff is always critical. But weight is related to many cancers. And so if we can do those two things, I think we've gone a long way to decreasing our own risks of cancer.
Dr. Ripka?
I think vigilance. I think, in addition to maintaining a normal weight and maintaining balance in your life, sun exposure, that stopped. Sun exposure, in moderation. Skin cancers are tremendously on the rise.
Okay, and that's about all the time we have. Thank you to our guest, Dr. Ralph Moss, also Dr. Jerry Driddell, and Dr. Vitek Ribka. For all of us here at WPSU, thanks for watching. Good night.